Well, thanks for the invitation to speak here, and I want to thank the organizers of this meeting. I think for me in particular, it's been very interesting and inspiring to hear what everybody's doing. I know about a lot of these organizations peripherally, but to have a place where everybody can come together and kind of talk about the work they're doing, and it's inspiring and it's exciting, and it shows that something good can come out of this horrible war. So I'm going to talk a little bit about the co-pilot project in particular that's now being run through Razum. Sort of lessons learned in the early years, what we were trying to accomplish then, how the co-pilot project has transformed after the start of the full-scale invasion, specifically in terms of the broadening of the scope of what we're trying to focus on. And then I want to talk specifically about my field, which is epilepsy surgery, as well as the penetrating brain trauma epidemic, unfortunately, in Ukraine, and how those things actually overlap. We started doing work in Ukraine after the Revolution of Dignity. And it happened, it was in Seattle that I met an English neurosurgeon, Henry Marsh, who first introduced us to Ihor Kurlets and his son. And these were neurosurgeons working in Kiev, and they were our first partners. I still remember it was a Zoom meeting we had with Ihor, and he was in Mariupol at the time. And it was that planning session that led to our first trip. And basically, our first trip was somewhat spontaneous. We basically went to, we heard about what capabilities they had in their center, what equipment they had, and we planned several intracranial surgeries to do together, mostly on benign brain tumors. And that was how it all started. As time went on, we started going more. A lot of the work that we were trying to do was to try to understand the landscape of neurosurgery in Ukraine, who is already doing what at a high level, and where could we support them? Where could we maybe fill deficits? So we brought many other surgeons. This is some pictures of a scoliosis group that we brought to do scoliosis surgery in Western Ukraine. Part of our mission was also to interact with students, interact with trainees, learn about their system, learn about, try to really appreciate the requests that they brought to us in terms of what they thought they needed to be better professionals. And, I think we also enjoyed sort of what was a cultural exchange. It meant a lot to us to bring friends of ours from different backgrounds, different ethnicities to Ukraine, and celebrate being there together. And I think at the end, basically what we were trying to do, and again, echoing what Kirsten was saying in the last talk, thinking about the kind of help that would be temporary and limited, because our Ukrainian partners didn't want to be the focus of our help all the time. They wanted to raise their own level to do high quality surgery independently, and that's this neat text at one point that I got from one of them about removing a brain tumor on his own, and so that was what we were trying to foster. So the early trips, as I mentioned, there was a variety of surgery that we did, but it was mostly vascular neurosurgery, pictures of aneurysm clipping, brainstem tumors, benign tumors, some epilepsy work. And again, just to mention some of the early lessons, and I think it applies to a lot of the groups that are doing trips into the country. One of the most important things that one of the things that really our efforts hinged on was finding good partners. What's a good partner? Well, a good partner was a partner who really wanted to be a leader in their field, really wanted to work hard and push the boundaries and become expert and also teach other people. And also one of our goals was to find good co-pilots. In other words, good surgeons from the United States who wouldn't just come to Ukraine and do the surgery and the Ukrainian surgeon would sit there and watch them, but somebody who could really teach and do a little bit and show. And the other things that we learned is that there was obviously an importance for repeated visits to the same center so we could really focus on the development of individual surgeons that we identified who were looking to be leaders in their field. One of the lessons we learned is there's no subspecialty that's an island in of itself. Neurosurgery, I'll tell you an early story. There was a patient who came to me in clinic, this was in Kiev, who he looked cachectic, he had lost his hair, and his mother explained that he was getting chemotherapy for a brain tumor. And we looked at the imaging, and it didn't look like a malignant brain tumor to us, so we sent his pathology. He had gotten a biopsy in Ukraine. We sent his pathology slides to the United States, and they said this is a benign schwannoma. So something that, obviously chemotherapy is not appropriate for that type of tumor. Surgical resection is the treatment. And so, again, we realized that obviously doing a good surgery, that's one thing, but having good support staff in the form of radiology, pathology, that's tremendously important too. And so we expanded our team in this sort of organic way. We started looking for other partners that could help us do the work that we were doing, and also partnering with people in Ukraine. So what was the quality of pathology, surgical pathology, and how could we have an impact on that? Obviously, neurosurgery is a highly technical field, so acquisition of appropriate equipment was important. And again, our collaboration early in our project with Razum became extremely important, because it allowed us sort of a collaboration with a 501c3 that had ability to do in-kind donations of equipment and had the logistics set up for that, and also obviously ability for fundraising. Early in our work, we thought it was important to get a sense of neurosurgery in the country. Obviously, we didn't want to come and offer a service that was already being offered in Ukraine at a high level. We wanted to identify where that was being done, so we took part in academic talks. We took part in neurosurgical society meetings, conferences, and I think all of that was quite important. And we also wanted to have some academic rigor to the work that we did, so we made sure to write about it, publish about our outcomes and the work we were doing. I'll just talk about some of the ways that our work expanded early on. When I first started going to Ukraine, I would try to assist with whichever cases they wanted assistance with, but as my own practice narrowed in the United States, I thought it was appropriate to narrow the help that I provided in Ukraine to epilepsy surgery and pediatric neurosurgery, sort of complex intracranial stuff, which is what I do here. But then we would look for other co-pilots who wanted to go to Ukraine and help with other types of surgery. Right now, the main surgical subspecialties that we're helping in is endovascular neurosurgery. Maxim Shapiro from NYU was a radiologist, interventionist. He was actually born in Kiev, so he's really taken the lead on that. And but we've had a number of endovascular surgeons go to Ukraine who have now gone in a repeated fashion, focusing on 4 or 5 centers there that they're trying to really establish as centers of excellence. Scoliosis, orthopedic surgeons, skull-based surgeons, endoscopic skull-based surgeons, epilepsy surgeons, DBS surgeons, deep brain stimulation, functional neurosurgery. We recently published a sort of a questionnaire about what were some of the perceived deficits among Ukrainian neurosurgeons in their own training, and functional neurosurgery, pediatric neurosurgery tended to top the list, so that's been a big part of our focus. I'm going to shift a little bit to talk about how things changed since the war and some of the work that Rocco Armanda specifically. So Rocco Armanda is a military neurosurgeon who contacted us in the early days of the war, and he's now been to Ukraine several times. And he mostly goes to Mechnikova in Dnipro and works with the gang there. And again, I think they've done a really excellent job of, Again, using this horrible war as an opportunity for study, as an opportunity for innovation. They've published a number of articles about their approach to penetrating brain injury in American neurosurgical journals with the help of Rocco and Alex Volodka and a number of other trauma specialists from the United States who have gotten involved in the project and now taken repeated trips. And just some of the other. So I think the last thing to mention is when it comes to epilepsy and traumatic brain injury, I do think that our focus moving forward is to try to, as I'm now focused on epilepsy, is to try to develop centers of excellence. That was something mentioned in the previous talk, but Ukraine, even with its current population, probably requires 10 to 15 centers of excellence for epilepsy surgery. But that's not counting the additional burden that will certainly they'll be facing in the post-traumatic epilepsy. As many as 10% of patients, just to read some of these points here, with severe TBI will develop epilepsy from their brain injury. And now obviously you have thousands of patients in Ukraine with traumatic penetrating brain injury. Post-traumatic epilepsy is more common with the penetrating rather than a blunt type of trauma. These seizures may begin years after the initial trauma, and so these patients require long-term follow-up. And again, increasingly, this represents a population of what we call drug-resistant epilepsy, so they actually have structural scarring, changes in the brain where medicine is often not going to give them relief, and they actually need those areas of the brain surgically resected. So again, it's what the small bit that we want to focus on to try to basically bring this full gamut of epilepsy surgery. We were happy to be part of the first hemispherotomy done in Ukraine, in Kiev, Romodanov, and we now have a surgeon who I think has done more hemispherotomies than I have in Ukraine, and so we're excited that we're able to train these guys who then go on to really make this a big part of their own practice, and then again, just like the last talk, then go on to train their junior surgeons, and so it's exciting to see that ripple effect. Obviously, this is the other sorts of surgeries that we're focusing on in epilepsy. One of the problems with epilepsy surgery is it is very technical. A lot of the surgery we do now requires robotics. It requires implants. One of the implants that we're putting on a lot in the United States for epilepsy, especially if it's multifocal or generalized, or involves what we call eloquent parts of the brain, is the NeuroPace implant, which costs $50,000 per implant. So, these are very helpful technologies. They're very expensive, and so trying to think about ways to introduce these technologies, first of all, in a sustainable way, but also to think about long-term financing is difficult. I guess the last thing that I'll just mention is I think, I'll mention that this is a neat story. I sometimes with my practice in the United States, we have a pretty broad practice, and we occasionally get queries from out of the country, and this family from Northern Ireland contacted me. They wanted to come to New Jersey for epilepsy surgery, but unfortunately it was cost prohibitive, and we said, do you want to go to Ukraine? And they said yes. And so it's a neat story because I'll tell you, the Ukrainian team, it was one of my shortest trips to Ukraine. I spent about 72 hours there just to sit on the other end of the microscope and watch the Ukrainian surgeon do the whole thing, which was fine. But again, I think it was a heartwarming story of how Ukraine can then take the knowledge that we give them and turn around and help elsewhere. So I'll end on that note. Thanks. Yeah.